Hi, it's a pleasure to be here today to talk about updates and targeted therapies for our metastatic non-small cell lung cancer. There are many exciting updates to review from some of our recent meetings, including the World Conference on Lung Cancer, which happened in Singapore in September of this year, and the ESMO annual meeting in Madrid in October. My name is Zofia Piotrowska. I'm a thoracic medical oncologist at Massachusetts General Hospital in Boston, and it's a pleasure to be here today. So jumping right in, we have a number of different updates to talk about, and I've broken them down really by oncogenes and within oncogenes by context. So the majority of the topics we're going to talk about first have to do with EGFR mutant non-small cell lung cancer. There have been two large randomized studies looking at combination therapies for first-line treatment of classical EGFR mutations, and we'll start with those, the FLAURA2 and MARIPOSA trials. We'll then talk about post-TKI treatment options, again for patients with classical EGFR mutations with some emerging data there. Next, we'll move to EGFR exon 20 insertions and a first-line combination strategy from the PEPION trial. And we'll then move on to a few other oncogene drivers in non-small cell lung cancer, specifically non-small cell lung cancers with HER2 mutations, RET fusions, and KRAS G12C mutations, and some emerging data for all of these subsets. So with that in mind, let's dive right in. First, looking at updates in EGFR mutant non-small cell lung cancer. So to set the stage here, I want to remind you that here we're talking about classic EGFR mutations. These are patients with EGFR exon 19 deletions and L858R mutations. As you can see in the pie chart on the upper right here, together these make up about 85% of all EGFR mutations in lung cancer. And most of you are familiar with the FLAURA trial, which established osimertinib, a third-generation EGFR inhibitor, as our preferred first-line standard. Osimertinib is an oral therapy. It's generally well tolerated and has a median progression-free survival of about 19 months in the first-line setting. And in recent years, we've seen a number of different combination strategies being developed really in the goals of improving that first-line standard of care. And so today we're going to talk about the outcomes of a few of these studies. First, the FLAURA2 study, which looked at the addition of carboplatin pemetrexed chemotherapy to osimertinib. Next, lazertinib plus the bispecific antibody targeting EGFR and MET, amivantamab. As a side note, this is a drug that you may be familiar with from patients with EGFR exon 20 insertions, but here applied in combination with a third-generation EGFR inhibitor for patients with classic sensitizing EGFR mutations. That's the MARIPOSA trial. And then I'll briefly tell you about some outcomes and ongoing studies with TKIs combined with anti-VEGF therapies, specifically osimertinib and ramucirumab with the OCRAM and RAMO studies. So with that, let's jump right in. I think the first and one of the largest studies to read out in this space over the recent months has been this study, the FLAURA2 trial. This was a study for newly diagnosed patients with classic EGFR mutations, exon 19 deletions, or L858R mutations. Importantly, these are all patients with advanced or metastatic disease who had had no prior systemic therapy for advanced or metastatic disease. And these patients here were randomized to either the experimental arm of osimertinib combined with platinum pemetrexed chemotherapy followed by pemetrexed maintenance, or osimertinib monotherapy as a control arm. You can see here that close to 600 patients were randomized, and the primary endpoint was progression-free survival by investigator assessment. These were the outcomes that were seen here. You can see that there was a clinically meaningful improvement in PFS in this study, 8.8 months improvement when chemotherapy was added to osimertinib, 16.7-month median PFS with osimertinib versus 25.5 months with the chemotherapy combination. Hazard ratio here was 0.62. The overall survival analysis here was immature, but you can see that the hazard ratio at this interim time point was 0.90, and this was not statistically significant. Now, we can tell that adding chemotherapy adds to osimertinib in terms of progression-free survival, but it also appears to add in terms of toxicities. And remember, here we're going from a purely oral regimen where patients are coming to clinic just once every few months for a follow-up to a regimen that requires an IV therapy where they're coming to clinic every 3 weeks for infusional chemotherapy. And as you might expect with the addition of chemotherapy, we do see more toxicities. You can see that in the tornado plot here. Most notably, higher rates of hematologic toxicities, anemia, neutropenia, thrombocytopenia seen with the osimertinib chemotherapy combination. We saw higher rates of treatment discontinuation. Nearly half of patients on the OC chemo arm discontinued one of the agents, most commonly pemetrexed, and this was quite uncommon in the osimertinib arm. Now, at ESMO this year, we saw a follow-up to the initial FLAURA2 presentation, which showed this nice analysis of these adverse events over time. And what you can see here is that, as you might expect, the toxicities were greatest, and particularly the hematologic toxicities were greatest in the first 3 months of treatment when you saw the addition of the platinum component to this regimen. And that after that 3-month mark, the toxicities were overall lower. So this, I think, is in keeping with what we might expect with carboplatin or platinum pemetrexed. We also saw that the median duration of exposure to pemetrexed here was actually only 8 months. And so that many of these patients, if you think about the totality of that median of nearly 26 months on first-line therapy, we're actually only on the chemotherapy component of it for the first part, and then we're on osimertinib monotherapy in many cases due to cumulative toxicities. And I think the outcomes of these patients by treatment duration will certainly be interesting to look at. So I think when we see a regimen that improves progression-free survival but also adds toxicity, we really want to identify patient subgroups where this may be particularly worthwhile to consider. This is still an ongoing area of investigation, but one subgroup that seemed to be identified in the post-hoc analysis as having a particular benefit here were those patients with baseline CNS metastases, which is about 40% of the FLAURA2 population. Here we saw that in those patients with baseline CNS metastases at initial diagnosis, the median PFS, you can see that on the left of this slide here, was improved with a greater magnitude of benefit, hazard ratio of 0.47, whereas if you look at patients without baseline CNS metastases, their medians were better across the board, which we would expect, but the magnitude of benefit of adding chemotherapy was lower with a hazard ratio of 0.75. And in a specific analysis of CNS outcomes presented by Dr. Blanchard at ESMO this year, we did see that looking at these waterfall plots, the depth of response and number of patients with complete responses to this regimen did seem to be higher when chemotherapy was added to osimertinib. And I think this really emphasizes the potential kind of added benefit of adding a CNS active chemotherapy regimen such as platinum pemetrexed. Again, this is an exploratory post-hoc analysis, but I think this does suggest that patients with baseline CNS metastases may have a particular benefit from the addition of chemotherapy to osimertinib. So I think FLAURA2 was an important study. It clearly showed that the addition of chemotherapy to first-line osimertinib does improve PFS in a clinically meaningful way, but it comes at some costs, particularly the requirement for Q3 week infusions, the increased toxicities. And I think it really will be important to identify which patients need this. And patients with baseline CNS metastases seem to be one population where there is particular benefit. I think first-line osimertinib plus chemotherapy is an option, particularly for our fit, high-risk patients, maybe those with baseline brain metastases. But in the absence of an overall survival benefit at this point, I think osimertinib monotherapy still remains a reasonable first-line treatment strategy for these patients. Mature overall survival data, I think, will be important to evaluating the role of this regimen. And ultimately, I also think that better risk stratification, perhaps based on those patients who do or do not clear their ctDNA after 3 weeks on osimertinib, may be a way to help select those patients that really need an escalated regimen like FLAURA2. Another first-line treatment combination that's been evaluated is the Mariposa regimen. And here you can see the study design of Mariposa. Unlike FLAURA2, which looked the addition of chemotherapy to a TKI, here we're looking at the addition of a bispecific antibody, again, amivantamab, which is a bispecific antibody targeting EGFR and MET, being added to a third-generation EGFR inhibitor, lazertinib, which is a drug very similar to osimertinib. The control arm here is osimertinib monotherapy, and lazertinib monotherapy was also evaluated. Very large study, more than 1,000 patients randomized to these 3 arms, and the primary endpoint here again was progression-free survival here by blinded review. And these were the outcomes. Again, a positive study. The study met its primary PFS endpoint. We can see a 7-month improvement in PFS from 16.6 months with osimertinib to 23.7 months with amivantamab lazertinib. Hazard ratio here was 0.70. Once again here, the OS is immature. This is an interim analysis. The hazard ratio was 0.80 for OS, not statistically significant at this time point. But if we look at the landmark 2-year survival, you can perhaps get a sense that maybe it's a bit better with the combination, 74 versus 69%. And so this will be something that we'll have to keep an eye on. Now, once again, we can see that, a combination regimen adds toxicities and again adds an intravenous regimen to a purely oral one with amivantamab given every 2 weeks intravenously. And what we can see in this tornadoes plot is that the toxicities that we know from amivantamab, particularly those related to EGFR inhibition, dermatologic toxicities, paronychia, rash, some MET-related inhibition such as hypoalbuminemia and edema, infusion-related reactions, and importantly, venous thromboemboli are all more common in the combination arm. We saw higher rates, again, of dose interruption, reduction, and discontinuation in the combo arm. And even though many of the dermatologic toxicities were low grade, that's the dark blue bars here were grade 1 and 2 toxicities, we have to keep in mind that these patients are staying on treatment for nearly 2 years. And so this can have an impact on their quality of life, particularly chronic paronychia, dermatitis, scalp folliculitis, and others. And this is something that we'll have to weigh in considering this regimen. We also saw that 37% of these patients had a venous thromboembolism on amivantamab lazertinib, and now prophylactic anticoagulation is recommended for the first 4 months of treatment with this combination, and that does seem to mitigate that VTE risk with this combo. So I think this is another regimen which now gives us another option of a combination which extends progression-free survival for first-line treatment of classic EGFR mutant non-small cell lung cancer. Here, the PFS improvement was 7 months, hazard ratio of 0.70. But once again, we see some costs in terms of the frequency of visits and the toxicities. I think if this regimen is approved in the first-line setting, it will represent another option to be discussed with our patient. But similar to FLAURA2, I think the toxicities and the lack of OS benefit thus far mean that this may not be universally applied. I think that, this will be a conversation with patients. And for now, for many patients, osimertinib monotherapy may remain a reasonable first-line option. I think what we really need here are overall survival data and then also biomarkers to help us understand which patients are most likely to benefit from this combination.
So I don't know if they presented any data on lazertinib alone versus osimertinib alone.
Yes, they did show that. The outcomes were very similar. They had the PFS was very similar.
Toxicity the same also?
Yep. They didn't specifically show that, I think, but in general, this has been shown previously. It is quite similar to osimertinib in terms of both efficacy, CNS activity, which is important, and toxicity.
And then the other question I had is, you mentioned VTE. Is that seen with amivantamab alone?
It seems to be, there are, you can see in the Papillon data, there's a low risk of that, but it seems to be particularly common with the amivantamab lazertinib combination. It's really unique to this combination. And only with the combination is prophylactic anticoagulation being required.
Okay, please continue.
Okay. So other combinations have, of course, also been evaluated in this first-line EGFR mutant treatment space. Many studies have looked at the combination of TKIs plus VEGF antibodies. Of course, there's a whole body of literature looking at first-generation EGFR inhibitors with both bevacizumab and ramucirumab. Notably, erlotinib plus ramucirumab was evaluated in the RELAY study, which improved progression-free survival and led to an approval in the United States. But many of these studies came out around the time that we moved to using osimertinib as our preferred first-line strategy. And so now we have several studies looking at the combination of VEGF antibodies with osimertinib specifically. 2 of these studies, which are highlighted in the green box on this slide here, were recently presented at the ESMO meeting. Before I get to those studies, I'll just briefly say that there had been a study of osimertinib with bevacizumab published in 2022 from Japan, which somewhat surprisingly did not show a significant improvement in progression-free survival with OCBEV, as you can see the numbers here. And then we have these 2 studies, each looking at the addition of ramucirumab to osimertinib, the RAMOS study from the United States and the OCRAM1 study from Japan. And what was interesting is that while the RAMOS study was a positive study, we saw an improvement in PFS from 15.6 to 24.8 months, clearly significant here. The Japanese study really did not show that. Indeed, showed almost the opposite. It showed a better PFS with the TKI alone than at 24 months than with osimertinib with ramucirumab, or the median PFS was 20 months. Now, the authors here did note that the Japanese study was really done during the peak of COVID and thus led to some challenges in this clinical trial. The median duration of exposure to ramucirumab was very short. I think it was around 4 months in this study. So I think there's a lot of caveats around this Japanese study. But nevertheless, the results with TKIs plus VEGF have been overall inconsistent, and none of the studies thus far have demonstrated an overall survival benefit. I will note that there's a randomized phase 3 study of osimertinib plus or minus bevacizumab as a first-line treatment strategy, which is ongoing in the United States. This is being run through the ECOG-ACRIN Cooperative Group System, EA 5182, and I think this, larger phase 3 study will hopefully give us a more definitive answer on the role of VEGF combinations here. Moving on then to managing progression on EGFR TKIs, I think we had a few interesting abstracts in this space as well. The pie chart on the left just briefly summarizes the resistance mechanisms that we see when patients undergo tissue biopsies after first-line osimertinib. And I'll just highlight a few key points here. The first is the large fraction of these patients in the yellow here where a targetable resistance mechanism was not identified. This was more than half of patients in this series retrospective cohort that we put together, which included 129 patients with tissue biopsies after first-line osimertinib. The second is that MET amplification, which is in this light green outer box here, was seen in 16% of patients, was really among the most common targetable resistance mechanisms that were seen in this cohort. MET amplification has been seen in 16 to 20% of patients who progress on first-line osimertinib, depending on the series that you look at, and we saw some data with the combination of an EGFR and MET inhibitor for these patients from the INSIGHT 2 study. So first, we're going to talk about Mariposa 2 and Herthina Lung 01, which represent two potential treatment options for patients with no identifiable resistance mechanisms or potentially options that are not so specific to one resistance mechanism or another. And then we'll review the results from INSIGHT 2, which looked at the combination of tepotinib and osimertinib for those patients with MET amplification, shown in that light green box here on this pie chart. So the Mariposa 2 study looked at the same combination that you're now familiar with of amivantamab and lazertinib, here added to platinum pemetrexed chemotherapy in the post-TKI space. So these are all patients who had prior osimertinib in the first or second line, and they were randomized to either amivantamab lazertinib plus chemotherapy, amivantamab and chemotherapy, or platinum pemetrexed chemotherapy alone. The primary endpoint here was progression-free survival by blinded review, and we looked at both the 4-drug and the 3-drug regimen compared to the chemotherapy control arm. And these were the outcomes. On the left here, you can see the objective response rate, which was nearly doubled with both ami chemo and amivantamab lazertinib chemo. And on the right, you can see the primary endpoint of progression-free survival, which was significantly improved again with both regimens, ami chemo or ami laser chemo, hazard ratios of 0.48 and 0.44. I think, these are certainly clinically meaningful numbers, particularly in the post-TKI setting where, we really have somewhat limited treatment options and I would say modest outcomes with chemotherapy alone, as you can see on these curves. Now, one intriguing aspect of this analysis was that they looked at intracranial progression-free survival. And what you can see here is that this was improved with both ami chemo and ami lazertinib chemotherapy. There was a lot of discussion about this point when this data was presented and afterwards. I think many of us expected that the lazertinib, which is a CNS penetrant TKI here, would really be required, particularly for the CNS benefit of this combination. But what this data is really suggesting is that maybe amivantamab, a bulky bispecific antibody that we wouldn't have predicted to have much intracranial activity, does seem to provide intracranial benefit when added to chemotherapy, even in the absence of lazertinib. And so I think one question is, do we really need all 4 drugs, or might amivantamab chemotherapy be sufficient here, both in terms of overall outcomes, but perhaps specifically looking at intracranial outcomes? And this is important because when we look at the toxicities of these regimens, you can see that the 4-drug regimen with lazertinib really had the highest and quite notable toxicity profile here. When we looked at grade 3 or greater treatment emergent adverse events, they were 92% in the 4-drug regimen and 72%, so still notable but not quite as high with ami chemotherapy. The toxicities here were the ones that we had seen with ami lazertinib, dermatologic toxicities, infusion reactions, and VTE, but coupled with the hematologic toxicities of chemotherapy. And you can see that the rates of interruption interruption, reduction, and discontinuation were also highest in that 4-drug regimen. So the study authors are evaluating a modified regimen where lazertinib will be added when patients complete the 4 cycles of carboplatin in the hopes that may mitigate some of these toxicities. But I think a key question here will be, do we really need the lazertinib component of this, or is amivantamab chemotherapy enough? But I do think that, these regimens do have clinical meaning here. They improve objective response rate, they improve progression-free survival, and improve intracranial PFS. But again, they come at the cost of increased toxicity. I think if these are approved, for now, I would probably favor the ami chemo as a post-TKI treatment option, particularly for patients with CNS metastases or based on the high response rate, those with high disease burden. We'll have to see what this delayed lazertinib regimen, how that performs in terms of both efficacy and safety. And again, like with Mariposa, I'm really hoping that biomarker analyses will be performed and will help us identify if there's a subset of patients that particularly benefit from the addition of amivantamab here.
Actually, when you think about it, there's really no particular reason to think the lazertinib would be effective, right? Because they're progressing on osimertinib, which, is, as you said, is basically the same thing. So I don't even know how it even got started when you think about it.
Well, many of us have kind of questioned what the role of continuing TKIs post-progression
Right,
in these patients. So we may have talked
right,
about this together before, how when patients, particularly if they've had CNS metastases in the past and those
right.
are maintained, when we switched to chemotherapy, many of us were continuing osimertinib, for example, and adding chemo. So I think the thought was it would have a similar benefit here. But I guess what it's telling us is if amivantamab is having, intracranial activity, then you don't need the TKI. Then you can, switch to something different, and that may work just as well.
Yeah, it makes a lot of sense.
What was surprising is that I don't think anyone really thought of amivantamab as a very CNS penetrant drug, extrapolating from the exon 20 space. And so, for that reason, I don't know if any of us were really expecting to see that degree of CNS benefit with it, just based on, we don't think of antibodies as necessarily being able to cross the blood-brain barrier so well.
Although, I don't know, seems like maybe there are exceptions to that. Although, yeah, I guess in terms of whether or not to add in the lazertinib, that's kind of a different issue. But
Yeah.
you're saying exon 20 insertion brain mets don't respond to amivantamab alone?
So far, it was more in the case report kind of, or in the anecdotal responses category. But, I will say, I don't know that it's been kind of robustly evaluated. They didn't have CNS kind of specific cohorts in those studies. And so I think we were probably kind of presuming maybe more than we should have. And again, the biology is different here with exon 20 than with the classical EGFR
Right,
mutations.
right. Okay, please continue.
All right. Moving on next to another treatment approach for patients who've progressed on TKIs, and in this case also progressed on chemotherapy with classic EGFR mutations. Of course, there's been a lot of excitement about antibody drug conjugates in non-small cell lung cancers with both actionable genomic alterations and those without. And we saw updated data with the HER3-directed antibody drug conjugate patritumab deruxtecan presented by Dr. Yu at World Lung this year. Patritumab deruxtecan is a HER3-directed ADC with deruxtecan, which is a topoisomerase 1 inhibitor payload. And in HERTHENA-Lung01, we saw a large cohort, 225 patients with classic EGFR mutations, all of whom had had a prior TKI and prior platinum-based chemotherapy. Here we saw a confirmed response rate of nearly 30%, 29.8%, median progression-free survival of 5.5 months. So I think clinically meaningful activity. And what was particularly interesting is if you look across the bottom of this waterfall plot here, you can see that patients who had both EGFR dependent and EGFR independent resistance mechanisms to their initial TKI therapy responded. We also saw responses in patients who had no identified resistance mechanism. And so I think this may represent an option that is, potentially active in patients regardless of what that post-osimertinib biopsy may show. What was also intriguing is in line with what we were just discussing with some of the antibody-based approaches and CNS outcomes, we saw that patritumab deruxtecan appears to have intracranial activity in this context. These numbers are fairly modest, but we saw a CNS-specific abstract presented by Dr. Johnson at ESMO. We saw that in HERTHENA-Lung01, among 30 patients who had brain mets but had no prior radiation to the brain, the CNS intracranial response rate was 33%. 10 of the 30 patients had a response response rate, including 9 who had a complete response, although I will note that 8 of these had non-target lesions, so likely some of these may have been small. We also saw that among the patients with a history of brain metastases, only 20% of them had progression within the brain. And among patients with no prior history of brain metastases, 97% of them did not have progression in the brain. So, potentially suggesting that this type of ADC may have a protective effect from the development of brain metastases as well. So I think patritumab deruxtecan is an important compound to keep an eye on. This appears to have broad activity in EGFR mutant lung cancer, post-TKI and post-chemotherapy, including patients with various resistance mechanisms. There have been intracranial responses that have been observed, which will be important as post-osimertinib options with CNS activity have thus far been really limited. And if approved, I think this will represent an important new post-TKI treatment option for EGFR mutant lung cancer. I will say that there are now studies ongoing with patritumab in combination with osimertinib in the first and second line setting. So we may also see this drug move up in our treatment strategies.
So I got to say, I found this a little bit confusing, and it kind of almost reminds me of the trope ADCs. Like, I'm not sure why you're targeting HER3. I've never seen anything about HER3 levels. Are they higher in this situation than up front? Why should this work?
So it's really interesting. They've always broadly said that HER3 is, enriched on non-small cell lung cancer and enriched on EGFR mutant lung cancer, but HER3 expression does not seem to be, most importantly, does not seem to be correlated with response to this drug. So they've looked at, tumor HER3 expression levels, and there's really no correlation with who responds and who doesn't. Nor do we see HER3 alterations of any type as a resistance mechanism to TKI therapy. So you're right. We really don't quite understand what the biomarker is here or why this drug works. And I think that's an area that we are trying to understand better, but we really have no kind of clear understanding of that so far.
The other thing is, given its last name, so to speak, what do we see in terms of ILD and GI toxicity?
Great question. The ILD rates there are ILD, but single digits, so much lower than what we see with the trastuzumab deruxtecan. And GI toxicities, the toxicities of this are, in my experience, largely kind of chemotherapy-related toxicities. So we do see a fair bit of nausea with this, not as much diarrhea, but certainly nausea can be seen, and hematologic toxicities also are quite common.
So I don't know if you could potentially envision a situation where you might actually have a choice between patritumab, amivantamab plus lazertinib, and probably other stuff you're going to present. But if we just stick with patritumab and amivantamab, any thoughts about if you had both, which one would come first?
So it's interesting. I think there's two parts to that question. If we think about a patient who's had prior TKI and prior chemotherapy only, and we take out, all of this data that we just saw with Mariposa and Mariposa 2, or Ami laser may move to earlier line settings. But in our current treatment landscape, where most of these patients, get a TKI, they get chemo, and now we're looking for a third line strategy. I think that the outcomes are actually quite comparable. Patritumab response rate, 30%. The amivantamab lazertinib on its own in that setting has a response rate of about 33%, similar PFS. I think what we really need is a biomarker, and there was some data presented at ASCO last year looking at MET IHC as a potential predictive biomarker of response to amivantamab lazertinib. It was small numbers, but if that pans out for a larger cohort and we could potentially use MET IHC to pick, that would be, to me, the best case scenario, because these drugs work differently, and I think if we can identify which patients are most likely to benefit from Ami laser, that would be my preference. Outside of that, I think the hope would be that patients could access both, and the question would be which sequence is best. And then I think the second part of that question is, how do we think about if Ami laser or amivantamab moves to earlier lines of therapy, right? Whether we give it in the first line setting based on Mariposa, or whether we give it in combination with chemotherapy based on Mariposa 2, that would then, I think, open the door for an ADC like patritumab to really be the only option once patients progress on those combinations.
But just let me get clear, though. Amivantamab, whether it's given with lazertinib or not, is given with chemo, correct?
In the Mariposa, so it can be given in different ways. So in Mariposa, in the first line setting, it could be given on its own, right, as a first line strategy. That was the first study we talked about. In Mariposa 2, they looked at it together with chemotherapy. And so the question is, will that be adopted? If it does, then yes, that's how it would be given. But older studies from Chrysalis 2 and others also looked at it as as a standalone in the TKI resistant setting, AMI laser.
But again, just to get clear though, if you were going to give amivantamab plus chemo, would that be third line chemo or second line, the first time you get chemo? You get
That's right.
osimertinib, and then when first relapse, do you get chemo plus amivantamab, or do you get, if you get chemo alone, is patritumab next? You can see where my confusion's coming from, like the second line versus third line.
It's very confusing. I totally see where your confusion is coming from. And in fact, I discussed two of these abstracts at ESMO, and I tried to make a chart
Right.
with kind of the lines of all the different options and how we could think about them. If amivantamab is given with chemo, that would be with a patient's first exposure to chemo. So most commonly in the second line, just like you said. So if we adopt that strategy, then I think third line after that, patritumab would be an appealing option, right? Because then it would be a totally different approach. If someone chooses not to give AMI with chemo and they say, it's not, I don't believe it, it's too tough, it's too toxic, and they only get chemotherapy, then I think you'd have the option of patritumab or AMI laser.
So you couldn't give patritumab alone without chemo as second line therapy after OC?
This data, I think that the approval that they're going to go for is post chemo, because this whole data set that with Herthina Lung 01, all of those patients had prior TKI and prior chemo. So the second line study is ongoing. It's being done alone, patritumab alone, or in combination with osimertinib, but we don't have that data yet. So I think their initial approval is going to be in the post chemotherapy space.
All right, please continue.
So moving on next to those patients who have acquired MET amplification following osimertinib or other TKIs, the INSIGHT 2 study looked at the combination of the MET inhibitor tepotinib with osimertinib. These were patients who were selected for MET amplification based on tissue biopsy or liquid biopsy NGS, and they were treated with a combination of tepotinib or osimertinib with a primary endpoint of objective response rate. As you can see in the waterfall plot down below, the response rate here was 50% to this combination with a median progression-free survival of 5.6 months. A very small number of patients, 12 patients here, were treated with tepotinib monotherapy and had a response rate of only 8%. I think really, this serves as a cautionary tale to remind us that for these patients, you need to continue the original EGFR inhibitor and add the MET inhibitor rather than switching to a MET inhibitor in this situation. We saw that outcomes were similar whether MET amplification was detected on tissue testing or by liquid biopsy or circulating tumor DNA. And we saw that the highest response rates were seen in the patients who had high level MET amplification detected by either method. We also saw that osimertinib and tepotinib had some intracranial activity with an intracranial response rate of 29%, which is perhaps not surprising as we know that tepotinib does also have some intracranial activity on its own. So overall, I think this data really provides proof of concept along with other similarly designed studies that the combination of an EGFR and MET inhibitor are active in our patients with acquired MET amplification after osimertinib. And again, just as a reminder, this is important to look for because MET amplification is among the most commonly observed resistance mechanisms in these patients. It can be detected by tissue and by plasma, although the ctDNA sensitivity is somewhat limited. The primary results of this study are consistent with TATTON and SAVANNAH and other studies showing similar outcomes with combined EGFR and MET inhibitors. And I think if approved, this will likely become a preferred treatment for patients with MET amplification. For now, we do sometimes consider off-label use based on case reports in select patients. And there are randomized studies now looking at these combinations of EGFR and MET inhibitors versus chemotherapy for patients with acquired MET amplification after osimertinib to determine which is the best sequence and whether these patients should get a MET inhibitor combination prior to carboplatin pemetrexed.
So just to clarify, though, that we're talking here about MET amplification as opposed to MET mutation or exon 14 skipping mutation. So just to clarify that, so in the upfront setting, am I correct in saying these MET inhibitors are of unproven or not of value with MET amplification?
So in the upfront, so when we talk about the MET mutations, that's kind of a separate subgroup of
As a
non-small cell lung
primary thing,
cancers.
right?
Yep. So
Right.
tepotinib is an approved drug for patients with de novo MET exon 14 skipping mutations. De novo MET amplification, has been looked at and is not quite as strong of a signal for response to MET inhibitors in the absence of an EGFR mutation, but they probably do have some activity. But the approval for tepotinib and capmatinib is for patients with de novo MET exon 14 skip mutations.
Right. And that what we're talking about here is actually patients who have EGFR mutations and then get MET amplification as a mechanism of resistance. So, like a difference. I know it's very basic, but again, for people who are seeing a million things, I think maybe important to clarify.
No, that's
Recover as
exactly
well.
right. Two different populations, and
Right.
I think different uses here in combination with EGFR inhibitors. Whereas, in those de novo MET exon 14 skip mutations, the activity is quite strong as monotherapy for a drug like
Right.
tepotinib.
Right. Exactly.
So moving on next to the management of patients with EGFR exon 20 insertions. And if we look at the pie chart on the right here, just to orient ourselves, recall that this is a subset of EGFR mutations. This is about up to 10% of EGFR mutations in lung cancer. And prior to ESMO 2023, so prior to this October, our standard of care first-line treatment for patients with EGFR exon 20 insertions was not a TKI, but remained platinum pemetrexed chemotherapy. With or without immunotherapy, there was still some debate in the field about that. But we had two drugs that had accelerated approval in the post chemotherapy space for patients with EGFR exon 20 insertions. The first is amivantamab, again, the same bispecific EGFR and MET antibody we've already been discussing, but here alone as monotherapy. This had accelerated approval in the post chemotherapy setting based on an objective response rate of 40% and a median progression free survival of 8.3 months. Mobocertinib is an oral EGFR inhibitor, which had accelerated approval in the post chemotherapy space, but is actually being voluntarily withdrawn from the US market after a randomized first line study was stopped for futility with a lack of improved benefit with mobocertinib versus chemotherapy. So, over the coming months, I think we can say that amivantamab is our only post chemotherapy treatment option, although there are other new EGFR exon 20 directed TKIs, which are now being developed in clinical trials. But what we saw at ESMO this year was this study, the Papillon study, which looked at a new first line treatment strategy where amivantamab is added to chemotherapy here. Again, here in this population, these are patients with EGFR exon 20 insertion mutation positive lung cancer, and this is their initial first line therapy. So these are treatment naive patients who are documented to have an EGFR exon 20 insertion, and a little over 300 patients here were randomized to a first line treatment strategy of ami chemo or chemotherapy alone. Those patients in the chemotherapy control arm had the option to cross over to second line amivantamab monotherapy, and the primary endpoint here was progression free survival. And here you can see the outcomes. On the left is the PFS curves here, and you can see an improvement from 6.7 to 11.4 months. Hazard ratio here was 0.395, so quite a marked reduction in the risk of progression. On the right, you can see the interim overall survival analysis. This is immature here. Hazard ratio was 0.675 at this time point. And you can perhaps start to see some separation of these curves, although I'll caution that the numbers are small at those further time points at this follow-up. If we look at response rates, we can see that the response rate was improved from 47% with chemotherapy to 73% when amivantamab was added to chemotherapy. And I won't belabor the safety table because this is really similar to what we saw with ami chemotherapy in the Mariposa 2 study. Overall, we can see that adding amivantamab to chemotherapy does add the toxicities we know and associate with amivantamab, including dermatologic toxicities, edema and hypoalbuminemia, to the hematologic toxicities of chemotherapy. Dose reductions were required in about half of the patients on ami chemo versus 23% of the chemotherapy patients, and about a quarter of them on ami chemotherapy discontinued one of the agents due to toxicities.
When I saw the thing about the Mobo, I was kind of surprised because when you want to use it like after amivantamab as a later line therapy, and are you
Yeah.
not going to be able to do that now?
That's right. It's a little bit of an unfortunate historical note. So, it has accelerated approval in the post chemotherapy space, but the confirmatory study for that accelerated approval was a first line study where they put
Huh.
mobocertinib monotherapy head to head with chemo. The
Wow.
mobocertinib monotherapy response rate was 28%. And so it's not perhaps surprising that in a head-to-head comparison versus first-line carboplatin pemetrexed, that response rate was not good enough to beat chemotherapy. And so it's not, it's being withdrawn not because it's inactive, but because it didn't meet that threshold in the first line setting. And it is too bad because it takes away our only approved oral option for these patients. And I hope that, there's a number of these oral drugs in development now that I think will come and hopefully that will change again. But for now, I agree with you. I mean, especially if we move amivantamab to the first line setting with Pepione, it leaves us with, without another option after this regimen or after Emi.
Yeah, I don't, your colleague Newport Raji, who's going to be doing an ASH symposium with us, will tell you they have an antibody drug conjugate in myeloma called belantamab mafodotin. You probably never heard of it, but same thing. The confirmatory trial is similar to what you just described. The confirmatory trial wasn't positive, but yet there are plenty of people out there walking around who responded to this
That's
pretty
right.
non-toxic drug. So they kind of got trapped in this sort of FDA approval, terrible thing.
Exactly.
And then
That's
now
exactly
you
right.
can't access it. And, I've been listening to you over the last few years say, oh, hard to decide between Mobo and Ami, and now Mobo's gone.
There are, a number of these drugs coming down the pipeline that I think are going to have a better safety profile and better efficacy based on what we've seen so far, other oral TKIs. So I suspect
That's
that
great.
they also may have decided that it's, something that is not worth their while to do another study. But I don't know. I mean, those are decisions that are made behind closed doors. So
Yeah, interesting. Okay, so I think you're going to finish out with some other targeted therapies in the metastatic setting.
that's right. So to summarize, in Papillon, we saw that adding amivantamab to chemotherapy significantly improves outcomes in terms of objective response rate and progression-free survival. For patients with EGFR exon 20 insertion, positive non-small cell lung cancer as a first-line treatment strategy, I think this really emphasizes the need to test for these mutations and identify these patients to select optimal therapy. And if approved, I think chemotherapy plus amivantamab will likely become our preferred first-line treatment for patients, although acknowledging the increased toxicity here. And, I think looking ahead, there are a number of novel selective EGFR exon 20 specific TKIs, which are in clinical trials now and may change our first line standard of care in the future. I hope that we'll still have good oral treatment options for these patients to come. So finally, moving on to a few abstracts for patients with other alterations, non-small cell lung cancers harboring HER2 mutations, RET fusions, and KRAS G12C. So jumping right in, for HER2 mutant non-small cell lung cancer, we do now have an approved agent, trastuzumab deruxtecan, a HER2-directed antibody drug conjugate, which was first evaluated in the Destiny Lung 01 study, which you can see on the left here. In the HER2 mutated non-small cell lung cancer cohort of Destiny Lung 01, trastuzumab deruxtecan had a response rate of 55%, median progression-free survival of 8 months, and a median overall survival of nearly 18 months. However, in that study, we saw that drug-related ILD occurred in 26% of those patients, with 2 treatment-related deaths related to ILD. So because of this concern about ILD and the hope of finding a better kind of efficacy safety balance, the Destiny Lung 02 study was designed. Here, patients with metastatic HER2 mutant non-small cell lung cancer, all of whom have had prior platinum-based chemotherapy, were randomized to 2 doses of TDXD. The Destiny Lung 01 dose of 6.4 milligrams per kilogram, or the slightly lower dose of 5.4 milligram per kilogram, each given every 3 weeks. The primary endpoint here was confirmed objective response rate, but of course, safety was an equally important endpoint here. And what we saw in Destiny Lung 02, on the left, you can see the efficacy. The outcomes were, I would say, fairly comparable with these 2 doses. Confirmed response rate of 49% at 5.4 mg per kg, 56% at 6.4 mg per kg, slightly shorter median PFS of 9.9 months versus 15.4 months, but nice tumor shrinkages at that 5.4 milligram per kilogram dose, as you can see in the waterfall plot here. I will note and remind you that here we're talking about patients with HER2 mutant non-small cell lung cancer. Most commonly, these are HER2 exon 20 insertions, and there's not direct overlap with either HER2 amplification or HER2 protein overexpression here. So really the biomarker for TDXD use in lung cancer is the presence of a HER2 mutation identified on NGS testing. On the right, you can see the safety of these two doses, and what you can see in the tornado plot is that overall toxicities were lower at that 5.4 milligram dose. And if we look specifically at drug-related ILD, it was indeed lower at that 5.4 milligram per kilogram dose, 13% versus a staggeringly high 28% at 6.4 mg per kg. So 13 is still a notable number, and we have to watch closely for ILD in these patients. But with all of this in mind, actually more than a year ago now, the US FDA granted accelerated approval to TDXD for patients with activating HER2 mutations in non-small cell lung cancer after a prior line of systemic therapy at a recommended dose of 5.4 mg per kg every 3 weeks. So that's the dose moving forward now. We also saw some CNS outcomes in HER2 mutant lung cancer with trastuzumab deruxtecan presented by Dr. Blanchard. And here we can see that in patients with intracranial metastases, whether you look at the 5.4 or 6.4 milligram per kilogram dose, we can see nice intracranial tumor responses to this agent. And on the right, if you look at the patients treated with Destiny Lung 02 or 01 at the 5.4 and 6.4 milligram per kilogram dose, you can see that the numbers are not huge here, but we do see intracranial responses with these. 7 out of 14 patients treated at 5.4 mg per kg in Destiny Lung 02 with baseline brain metastases responded. 9 out of 30 patients at 6.4. And at the bottom in the orange table, we have highlighted the patients who had no prior treatment, so no prior radiation. And again, small numbers, but we saw that 3 out of 6 of these patients had an intracranial response to TDXD, 6 out of 16 at the 6.4 milligram dose. So I think, again, this kind of disrupts our previous paradigm thinking that ADCs may not be so CNS penetrant, really highlighting that TDXD can have some intracranial activity for these patients. Now, when we put patients on TDXD, I think it's still really important to evaluate them closely with our radiation oncologist to decide which brain mets can be treated with a drug like this versus which need stereotactic radiation. And these are decisions I'm often making with the radiation oncologist and watching patients very closely if I'm starting them on an ADC like this. But this does give us, I think, the tools to start to think about perhaps starting with a systemic therapy like an ADC for these HER2 mutant patients if they have a small asymptomatic CNS metastasis. So I think these data really confirm the activity of TDXD and also confirm that toxicities are better at 5.4 milligrams per kilogram, although I'll note that 12% ILD rate is still something that's important to keep in mind. As I mentioned, there is some intracranial activity, and going forward, Destiny Lung 04 is looking at the first line use of TDXD. So these are newly diagnosed patients with HER2 mutations in lung cancer, randomized to TDXD or chemoimmunotherapy. So I think this may potentially change our first line treatment strategy in the years to come. And here again, we have HER2 selective EGFR sparing oral TKIs, which are now in clinical trials, and hopefully it will give us treatment options beyond TDXD in the future. Moving to RET fusion positive cancers, I think this study really serves to reaffirm our current standard of care. This is Libretto 431. Which took patients with newly diagnosed RET fusion positive cancers and randomized them 2-to-1 to the selective RET inhibitor selpercatinib, which you're probably all familiar with because this is a drug that already has accelerated approval for RET positive disease, as does pralsetinib, another selective RET inhibitor. But with that accelerated approval came the requirement for this registrational study, which looked at selpercatinib versus platinum pemetrexed chemotherapy with or without pembrolizumab. Here, patients on the control arm could have optional crossover to selpercatinib. And as you might expect, the outcomes were clearly better with selpercatinib, both in terms of progression-free survival on the left. The cumulative incidence of CNS progression was lower in patients treated with selpercatinib, which is not surprising because we know that this is a highly CNS active therapy. And the adverse event profile was as expected with selpercatinib. We did see higher rates of AST, ALT increase, and hypertension. Those are known side effects of selpercatinib, but no surprises in terms of toxicities. So, I think Libretto 431 really reaffirms the practice that we already have of using selective RET inhibitors as first-line strategies for patients with RET-positive lung cancer. An interesting side note was that similar outcomes were seen in the control arm, whether or not patients received pembrolizumab with chemotherapy. And I think this highlights the likely limited role of immunotherapy in patients with RET-positive cancers. And I think in terms of future directions, there was a lot of discussion in Professor Bess's discussion of the study as to whether we really need these confirmatory randomized studies when you have such a very active drug like selpercatinib in a rare patient population, and whether these types of studies are needed going forward. And then finally, moving on to KRAS G12C positive cancers, we had two small but interesting data sets presented. The first was presented by Dr. Clark at World Lung. This was Codebreak 101. This looked at the combination of sotorasib, an oral KRAS G12C inhibitor, which again has accelerated approval in the United States in the post-chemotherapy setting, but has, I would say, modest activity with a response rate around 40%. And here, trying to improve upon that, particularly looking at frontline therapy, combining sotorasib with carboplatin pemetrexed chemotherapy. This was a small cohort of patients, 20 patients treated in the first line setting with sotorasib plus chemo, 13 patients in the second line setting. Most commonly, this was second line after immunotherapy. And we do see nice responses here, 65% in the first line setting, 54% in the second line setting. Small numbers, but certainly notable response rates and no unexpected safety signals. We do see, hematologic toxicities, but that's to be expected with a chemotherapy combination. So this is a strategy that sotorasib is pursuing as a potential first-line strategy. Patients will be randomized to sotorasib plus chemotherapy versus chemotherapy alone in the PD-L1 negative population, trying to really think about how we can move sotorasib to our first-line regimens. Similarly, we also saw results with adagrasib, the other oral KRAS G12C inhibitor, which has accelerated approval post-chemotherapy in the United States. In Crystal 7, we saw the combination of adagrasib with the PD-1 inhibitor pembrolizumab, here again in previously untreated KRAS G12C positive tumors. On the left, you can see the safety tables. And what was notable here is that the safety was overall as expected. There were no unexpected safety signals, and most notably, there were not excessive risks of hepatotoxicity, which has been seen in other KRAS G12C inhibitor combinations with immunotherapy, like sotorasib. When you look at the ALT, AST increase in that bottom table there, we do see it, but largely these were grade 1 and 2, and the rates of high-grade hepatotoxicity were fairly low, which is reassuring. On the right side, you can see the efficacy, and here on this analysis, they focused on patients with PD-L1 high tumors, 50% or greater. Response rate here was 63%, and these appear to be durable. 60% of these patients remain progression-free at 12 months, as you can see on the swimmer's plot there. So, both of these drugs have accelerated approval in the pre-treated KRAS G12C positive lung cancer population, but I think it's fair to say that with both of them in that context, their activity leaves room for improvement. And so in the first line setting, we see promising response rates with both of these combinations, sotorasib with chemo and adagrasib with pembro, and the safety profiles of these overall appear to be as expected without excessive kind of toxicities, particularly with the immunotherapy combination. And there are randomized phase 3 studies that you can see here in the frontline setting with sotorasib with chemotherapy in the PD-L1 negative patients, that's Codebreak 202, and adagrasib plus pembro versus pembro alone in the PD-L1 high KRAS G12C positive patients. That's the adagrasib kind of development strategy. So stay tuned for more to come on both of these agents and how they may move up in the frontline treatment strategy, into the frontline treatment strategy.
It's interesting. I'm trying to think about other studies, at least that got this far, combining targeted therapy and IO. I don't think they're, you have this thing about IOs don't work, they cause toxicity, et cetera, but then you have here and, BRAF maybe, where I hear a little bit about IOs. What is your take in general on sensitivity, anti-tumor benefit with IOs and KRAS G12C?
I think that these are more, because KRAS G12C tend to occur in patients who have a smoking history more commonly than, for example, EGFR or ALK. The immunotherapies do work in these patients, and we really think about them, more akin to a wild type population where immunotherapy clearly has a role. So I think that's the difference here. That's why this is being developed more. The question of safety obviously is a big one, and the sotorasib plus immunotherapy did not seem to work out so well with, high rates of hepatotoxicity, but it does seem so far at least that adagrasib may be a little bit better tolerated.